I want to welcome everyone to the Michael J. Droller Chief Resident Debate for 2021. And for those of you who don't know me, I'm Luke Cavusi. And I've had the honor of being the president of the section this year and want to thank everyone for your support and hard work during this memorable year. In terms of tonight, I think this is really one of the jewels in the crown of what we do in the New York section, the resident debate. And it is a great educational experience for the residents. It's a great educational experience, I know, as faculty, and we see interesting things, learn interesting things. I want to start by thanking the residents for participating, taking the time. I want to thank the faculty for educating the residents and those of you who helped coach your residents through this. And there are no losers. Everyone gets a cash prize at the end of this, as is the world today. But you're all winners because of participating in this. At the end, they're going to be the highest scorers by our judge, and the highest scores will go on to represent our section in the national AUA contest. And I'm proud to say this started about 2 years ago or so, and New York section has won first prize in, I think, the first 2 of 3 competitions. So we have a great track record in doing well in this, and I know you're going to make us proud tonight. Your program's proud tonight, and you're going to make the section very proud going forward. I want to introduce our judge tonight, which is Dr. Li-Ming Su. And this is special, unfortunately, Dr. Su, because of circumstances, cannot come to New York, but he is very familiar for New York because he is a former resident of New York Hospital. And he distinguished himself as a resident there. He further distinguished himself as, and I know him as a fellow when he was down in Hopkins and then on staff there, and has gone on to become the chief in Gainesville, Florida. He is internationally known. He's just become, of many of his accomplishments in the world of oncology, minimally invasive surgery, prostate cancer. He has recently become the Secretary General for the World Congress of Endourology, for the Endourology Society, which is a great honor. And it just shows to his abilities and contributions. So I appreciate Dr. Su taking the time this evening to help judge this. And knowing him, he is a very measured and very fair individual and will give everyone great feedback. I also want to thank my partner, Dr. Jessica Kreshover, who helped organize the debate tonight. She came up with tremendous questions. Want to thank the entire board of the New York section for looking at the questions and making tweaks here and there, but they're absolutely wonderful and absolutely fair. And I think they're one of the best groups of questions that have come across. So thank you, Dr. Kreshover, for your help. As always, want to thank Michelle Pioli for making this possible in its very unusual format. We're used to all getting together and having a sumptuous meal at the New York Academy of Medicine, which hopefully we'll be able to do next year. But she did a great job putting this together. I want to thank Mike for helping with the AB portion of this. And again, just go over the ground rules, which you know. Be nice. You have your initial 5-minute presentation, 5 slides. You have 1-minute rebuttal with a slide. You get penalized for going over. Please do not go over. Please do not use profanity. Please, again, be gentle people and do not, no meanness to your colleagues or any I can't say pornography because we're urologists, but what would be perceived within urology pornography, to put it that way. And you all know it when you see it. And again, want to thank each of the industries that have helped support this. And again, this would not be possible without their help. Abview, Ambu, Coloplast, Heltronics, My Advanced Sciences, Neotract, TexFlex, Richard Wolf, Tolmar, Traverse, and Urigen. And please, you can look at their websites, find out more about them. The residents probably know more about each of these companies than the attendings do. So, but the attendings are welcome to also. And with that, I'm going to turn things over to Dr. Kreshover, who's going to run the evening. And again, thank you all. And thank you again, Dr. Sue, for joining us this evening.
So thank you, everybody, for joining us. I also want to thank Dr. Sue, thank all the residents for presenting. To echo what Dr. Cavusi had said, this is one of the most wonderful events that the New York section hosts. And I think, as always, despite its virtual format, we hope to have the entertainment factor and learning factor still continuing this evening. So our first two debaters are Dr. Caputo and Dr. Billa, and presenting first will be Dr. Caputo presenting nephrectomy for this young lady.
Great, thank you for having me present to the New York section chief debate tonight. It's definitely an honor and privilege to be here. So let's get started with the first patient of the evening. So this is a 34-year-old female. She's a type 1 diabetic, and she's referred to you after an ER visit for severe left-sided flank pain. Here are images of the CT scan performed at the time of her ER visit. Here you can clearly see that the left kidney is severely hydronephrotic to the left, on the left side to the UPJ, significant loss of renal parenchyma. This is all consistent with the UPJ obstruction. A renal LASIK scan was performed, which showed 20% function in that kidney. So you have a patient with a symptomatic left UPJ obstruction and poor renal function. And the question is, what is the best treatment option for that patient? So the three more common treatment options in practice for UPJ obstruction are either observation or the more radical interventions of nephrectomy or pyeloplasty. I think even my opponent would agree that observation is a bad option in this patient since she is both symptomatic with pain and has poor renal function. As with any surgical treatment, considering all patient factors is key. Ultimately, I believe in the decision-making in this patient's case is heavily weighed by two key factors about the patient, which is why I argue that nephrectomy is the better option. Number one, this patient has type 1 diabetes. We already know that diabetes is a major risk factor for most operative complications. However, diabetes has furthermore been reported as an independent predictor of failed pyeloplasty, as published by Tan et al. The Journal of Urology in 2011. This may be secondary to microvascular compromise resulting in anastomotic necrosis, and others have shown similar findings in radical prostatectomies as well as urethroplasties. Number two, this patient has poor differential renal function in the left kidney. There is inconclusive data on improved renal function after pyeloplasty in adults. Being that she has certainly had increased odds to have minimal or no renal functional benefit with pyeloplasty, an alternative option would be to place a uterine stent or nephrostomy tube and reassess her renal function to decide if pyeloplasty would be worth the risk. This study reported that individuals with differential renal function less than 30% had no improvement in renal function after pyeloplasty. Don't forget, our patient has 20% split function. Another study showed that the median improvement in split function was only 7% after 1 year from pyeloplasty, with those less than 20% function. Therefore, at the very least, our patient is already at higher risk for failure or minimal improvement in her already poorly functioning kidney if she were to have a pyeloplasty. Therefore, I argue without a doubt that nephrectomy is the better option for this patient. It essentially eliminates all the complications associated with pyeloplasty, which include failure in 20% of the time, need for reoperation in 10 to 20% of the time, urine leak in 5%, and persistent pain in around 5 to 10% of the time. Furthermore, our patient has diabetes, which is a risk factor for all of these complications. On top of this, our patient has poor split renal function and, as previously noted, would less likely benefit from pyeloplasty. So the main benefit of pyeloplasty is an attempt at preserved renal function, with her, as we discussed, and it is not clear if she will benefit much in this patient. With her type 1 diabetes history, CKD and renal failure may be in her long-term future regardless of intervention. It is important to note that renal transplantation is always an option in the future if needed, and studies have shown excellent quality of life outcomes after renal transplantation. So when your patient asks you, "Doctor, what do I do?" you tell her you're the ideal candidate for nephrectomy because of poor split renal function. She's symptomatic and has a significant comorbidity such as diabetes, which puts you at risk for increased risk for future infections within the kidney and further postoperative complications. This therefore also means a decreased need for reoperation, and this is the option, furthermore, that is most likely to get her pain-free. Thank you.
All right, so let's get started. We have a 34-year-old female, history of type 1 diabetes, who presents with diagnosis of left UPJ obstruction. Lasix renal scan shows 20% function of that left kidney. So let's get right to it. Let's start with the facts. No fake news here. Let's get with the real news. This is a young female. She's got a 50-year life expectancy in the US. She's got another 50 years to go. She's a diabetic, she's symptomatic, and she's got a confirmed left UPJ obstruction with 20% function of the left kidney. Now let's talk a little about the fake news that Joe Caputo is out here spewing. He might be talking about, he's worried about diabetes and he's worried about this infection history. Has she even tried a stent? We don't know that. What's her degree of pain? Other fake news that Joe Caputo is trying to put out there, some fake images. Where did he get those images? We don't know. Let's focus on the facts and work with the real news here. Nephrectomy is not indicated in this patient. You do nephrectomy when you have a recurrent infection, fake news. You do nephrectomy for XGP, fake news. Nephrectomy is for severe pain. Again, we don't know the degree of her pain, fake news. Non-function of the kidney, Joe Caputo is out there trying to say that this kidney is not working, but it's got 20% function, fake news. Do we know anything about the normal contralateral kidney? We don't know. Joe Caputo is even pushing to get this patient a transplant already. Fake news. Solitary kidney is dangerous business, leads to ESRD, and even Joe Caputo says can eventually lead to a transplant. That's not what we want in this young female. Now let's turn to the Holy Bible of Urology, and I read a passage, and I know Joe Caputo read the same passage here. It's also known as Campbell and Walsh. It's the potential for salvageability of function is still unclear. An internal stent or nephrostomy may be placed for temporary relief and renal function subsequently repeated. We know that we can be conservative. Why jump the gun and go to a nephrectomy? Pyeloplasty works. Let's go to the facts. Here's one paper. Shout out to one of my mentors, Dr. Michael Stifelman. 140 patients, 95% success rate. Here's another study. A couple of more mentors out here, Dr. Mudahar Ahmed, Dr. Greg Lavallo, Dr. Munver, and Stifelman again. Here, 158 patients. In the even more complicated reoperations, 85%. And in the primary, 92% success rate. Pyeloplasty works. Now let's go to the future. I'm talking SpaceX. I'm talking Tesla level. I'm talking Elon Musk approved. I'm talking single port surgery. Now, granted, I happen to be the first author on this paper, but it works. Look at that. Oh, you can't even tell that this lady had an incision, had a surgery. You can do a pyeloplasty through that tiny little hole and get this patient home and comfortable and keep her kidney. Joe Caputo, you're a good guy. You come from the AUA New York section. You went to Stony Brook Med School. You and I met at Downstate. You were the sub-I, and I was a third year. And you went off to Columbia, where the roles reversed. You were the sub-I, and I was the med student. You were the intern, and I was the sub-I. We know the knowledge. We share the same background. We know the truth. Pyeloplasty is the right answer. I heard you just got married, so congratulations on the wedding. Enjoy your honeymoon, and let me do the pyeloplasty. I'll get the case done before you even land.
Excellent. And now you both will have 1 minute for the rebuttals.
Although my opponent has argued for preservation and improvement of renal function with pyeloplasty, I say it's highly questionable. I previously showed you data to support that, but guess what? There's even more data out there. This study in 1999 by McClear et al. Concluded that in 79 patients, there was no difference in renal function after pyeloplasty. Another study, a recent retrospective review in the pediatric population, also showed that 36% of patients undergoing pyeloplasty had improved function and 45% had no improvement. And this was in the pediatric population. So you can infer that after many years of obstruction, outcomes would be worse in adults. In this last study of 211 patients, the mean improvement of renal function was only 4.4% in those with baseline split function less than 30%. So I ask, with the low likelihood of renal improvement and high complication rates, especially with type 1 diabetes, is pyeloplasty really the option and I boldly state it is not correct.
So now let's go to the Joe Caputo podcast, aka Fake News Central. He's spewing out all this nonsense that pyeloplasty doesn't work. He's talking about non-functioning kidneys, recurrent pain. He's talking about quick surgery to just get this kidney out. And he's focusing on the diabetes and recurrent infections. Nephrectomy, simply put, is not risk-free, and nephrectomy is not cheaper. He's talking about giving this patient a transplant down the line. I know Joe Caputo knows the answer. At least give this patient a stent or nephrostomy. I know there's still some function to save. He's quoting some paper saying that pyeloplasty doesn't work. We know pyeloplasty works. We know pyeloplasty results in radiographic resolution of these obstructions. Let's fix what we can. Nephrectomy is not the only one and done answer. Pyeloplasty is the way to go. The reality is pyeloplasty is safe and effective, has been around for years, and is well documented. Late onset UPJ, it happens. Solitary kidney, dangerous business. Let's not go there. Our obstruction can be fixed, and let's fix it. Go enjoy your honeymoon. I'll get this pyeloplasty taken care of.
That was great. Thank you both very much. Again, for everybody, if you join the chat below our screen, just log in with your name, and now you can vote for who you feel won the debate. All right, so up for our next debate, our first presenter is Dr. Karan Emeryua, who will be presenting the HoLEP and cystolitholepaxy option for our gentleman with urinary retention and bladder stones.
All right. Good evening, Dr. Cavusi, Dr. Kreshover, Dr. Su, colleagues and guests. My name is Karan Emeryua. I'm Chief Resident at SUNY Downstate. So you know it must be the year 2021 as we're about to have a debate in urology about lasers versus robots. But as we all know, when laser meets robot, laser wins. To frame this argument tonight, I'll open with this. If you do not believe the best management for your patient is a less invasive, non-inferior treatment with less perioperative morbidity, how can you call yourself a minimally invasive surgeon? There's no doubt that HoLEP and cystolitholepaxy offers our 63-year-old gentleman in urinary retention with two 2-centimeter bladder stones and 120-gram prostate, the safest, most effective treatment overall, but especially when compared with robotic simple prostatectomy. HoLEP's far less invasive. By a transurethral approach, without switching instruments or even laser fibers, we can treat 2 stones, we can proceed with prostate enucleation, we avoid incisions, we avoid the patient's potentially hostile abdomen, and we have no cystotomy. HoLEP's been proven in extensive research to be non-inferior to the AUA guidelines gold standard treatment for BPH, the TURP. Non-inferiority has been proven in multiple subjective and objective functional outcome measures, including IPSS, Qmax, and post-op PVR. The first prospective randomized controlled trials for HoLEP were performed as early as 1997, and the literature is now spanning 2 decades, demonstrating a durable treatment response even at 5 years. Finally, in my opinion, the best quality of HoLEP is the minimal perioperative morbidity. HoLEP's safety profile is so strong that the EUA guidelines, European guidelines, state that when the prostate volume is greater than 80 grams, HoLEP is actually recommended over TURP. There's less cath time. The physics of the holmium laser provide excellent coagulation with minimal blood loss, which means basically non-existent risk for blood transfusion. And finally, a decreased hospital stay. But this is just me talking. What does the data show? It'd be too cumbersome for me to go over all the randomized controlled trials for HoLEP, but this conventional meta-analysis by Lee and colleagues published in 2014, directly comparing HoLEP to TURP, pretty much tells a story. In the top left, IPSS data acquired from 7 trials. At 3 to 6 months, no difference between HoLEP and the gold standard, but at 12 months, a mean reduction in nearly 19 points is clinically significant. This highlights HoLEP's ability to completely enucleate the adenoma from the prostate capsule, unlike TURP, leading to this durable treatment response. In terms of further objective measures, look at Qmax gathered from 8 trials in the bottom left. 855 patients on Euroflow, no significant difference between HoLEP and the gold standard, with a mean improvement in Qmax in 10 mLs per second. In terms of perioperative indicators in the bottom right, average operative time for HoLEP is only slightly longer by 15 minutes, but there's shorter cath time by a day or 2 and shorter hospitalization because the patients can go home the same day. If you look at intraoperative complications, Strong advantage for HOLEP in terms of blood transfusions because you never need them. Well, I mean, is it even necessary to discuss any further more invasive treatment? I mean, I'm happy to discuss the head-to-head data though. We look at HOLEP versus robotic prostatectomy. Given the nature of today's discussion, there's no doubt that simple prostatectomy is also an effective treatment for BPH. However, is it the best management? There are limited head-to-head studies. However, looking at this trial, the Journal of Urology in 2016 just puts the discussion to rest. Both groups showed improvement in Qmax, PVR, IPSS, none of which were significantly different. But if you look at mean catheterization time, mean hospitalization time, and even the median weight of the adenomic size, all showed advantage for HOLEP. So of course, I mean, we're talking about a gentleman who has had a stab wound and a prior XLAP. You know, why would you even consider at this point doing a robotic simple? So look at the data, do what's right for our patient, and ask yourself, can you call yourself a minimally invasive surgeon? Thank you.
Okay, good evening, everyone. Our case tonight is a 63-year-old gentleman with urinary retention found to have 2 2-centimeter bladder stones and a 120-gram prostate. His past medical history is significant for a stab wound, status post an XLAP 19 years ago. Tonight, I'll convince you that performing a robotic simple prostatectomy is a superior procedure. A robotic simple prostatectomy is the best procedure for 2 reasons. Number 1, it's available, widely available. And number 2, it's a smart investment. Firstly, robotic simple is a widely available procedure and incorporates generalizable skills familiar to all of us during training for robotic male pelvic surgery. The HOLEP has a really steep learning curve, making it highly unavailable. Competent HOLEP surgeons are so hard to come by that one patient even flew from California all the way to Philly in the middle of a COVID epidemic just for this elective surgery. And there's a reason for how unapproachable the HOLEP is. Let me provide you a visual narrative for a typical HOLEP. First, things start up fine. You think you have the right plane, you get into a little bit of bleeding, but that's okay. But then the circulating nerve starts to struggle with a tremendous amount of irrigation requirement. Now, what was just some minor bleeding now obscures your view, and the whole OR is full of bloody irrigation. At this point, it may be too bloody to even see. You may have to convert to a TURP. Or you can forge forward, try to proceed with morcellation, and shred the bladder, shred the intestines. So that insult to injury, you need a high-powered laser to fragment both the stone and enucleate the prostate at the same time. Without it, you may end up doing the procedure in 2 stages or opening up. And don't forget the cystolithopaxy. What are you going to do when your morcellator jams from a bladder stone fragment? So as you can see, the HOLEP has a notoriously difficult learning curve. Multiple papers have cited a learning curve of 50 cases, 20 with mentorship for HOLEP. And even at that point, surgeons have variable performance. If you look at this graph, you can see that even with experience, there's a wide distribution of enucleation efficiency. In contrast, it takes 5 cases to achieve proficiency for robotic simple. So the HOLEP is a demanding procedure marred with a steep learning curve. On the other hand, a robotic simple is readily available and is better suited for wider adoption to urologic practice. Secondly, the robotic simple is a smart investment. While there may be an initial upfront cost, and as Curran mentioned, there may be increased catheterization time, increased hospital stay, the payout is getting the job done right the first time. As of course, hospitals that already own the Da Vinci system already offset the cost of robotic simple. There is no payout with the HOLEP. Studies have shown that even with experience with HOLEP, you don't diminish complications. As you can see here, while perioperative complications and post-operative stress urinary incontinence decrease for every 20 procedures performed, these rates did not improve after 40 cases. You plateau. Your complication rates do not improve no matter how many more cases you perform. But not only that, making hasty decisions to perform HOLEP will cost your patient valuable time and money. You put your patients at risk for bladder complications like bladder injury, bleeding requiring reoperation, and more insidious complications like strictures, bladder neck contractures, and stress urinary incontinence, which is not only embarrassing and uncomfortable for a patient, but will require them to wear sanitary pads, subject them to another cystoscopy, getting UBS, time with physical therapy, and maybe you bought them another procedure with an artificial urinary sphincter. On the other hand, robotic simple has negligible rates of stress urinary incontinence. Additionally, if you invest in HOLEP, you bought your patient a painful recovery. One study showed a 50% increase rate of dysuria in HOLEP compared to a robotic simple. So do things right the first time. The robotic simple prostatectomy is widely available and a smart investment for your patient.
All right, so I figured Dr. Ng would mention the learning curve. My thoughts on that, are we too prideful to send our patient to a more experienced surgeon and therefore willing to put our patient through a more morbid procedure? And think about this, since HoLEP is prostate size independent, how long would it take to reach proficiency in real practice versus robotic simple, given the number of glands in the BPH-less population over 80 to 100 grams? You mentioned 5 versus 50 cases, 10% of your prostates are actually going to be over 100 grams. And at the end of the day, are most urologists in the population treating BPH more comfortable with the device on the left or the device on the right? What do our own guidelines say? I mentioned already the European guidelines. Our own guidelines give a grade B recommendation for HoLEP and ThulEP over simple, and and grade C for simple prostatectomy. Again, this just shows the strength of the literature as determined by our own expert panels. And finally, why risk it? Benign robotic surgery in a patient with a hostile abdomen could be considered reckless. Didn't mention extraperitoneal approach, but we just don't know the long-term efficacy rates or learning curve for that.
Okay, the more you know. Curran just mentioned that this patient has a hostile abdomen, but we know that, and as such, we can take steps to ensure patient safety. Firstly, numerous papers have documented the safety of laparoscopy after previous abdominal surgery. We take robotic radical prostatectomy as a proxy. Multiple studies have demonstrated no difference in operative time, EBL, rate of conversion to open, and rate of complications between patients with and without previous surgery. Additionally, the Hassan technique circumvents the potential risk of two blind passages. And lastly, performing the robotic simple prostatectomy using the extraperitoneal approach will allow you to avoid bowel-related complications. Will allow you to avoid bowel-related complications as well as the benefit of having faster patient convalescence compared to a transperitoneal approach. So it's clear that the robotic simple prostatectomy is widely available. It's a smart investment for patients. And obviously, the more you know, the safer you can make the procedure.
Awesome. Thank you both very much. Our first presenter is Dr. Jeremy Slawin, presenting the suprapubic tube placement for this patient.
Okay, good evening. Tonight we're going to be discussing why placing a suprapubic tube is much superior to ileal conduit as the initial management for detrusor sphincter dyssynergia. So which patient do we need to decide this for? It's a 28-year-old male who suffered a spinal cord injury 2 years ago, currently managed with an indwelling catheter. His urodynamic study reveals DSD and he cannot perform CIC. And we're tasked with deciding between an ileal conduit and a suprapubic tube as his next step in management. So let's take a little bit of a closer look at our patient and figure out what his goals and preferences might be. He's a young man. He has not sought management for his bladder in the 2 years since his injury, and this actually makes a lot of sense. We can imagine him as a young professional, probably a recent college grad from a fine university like the University of Florida, and he's trying to live as normal of a life as possible. Not to mention his injury was likely very traumatic, and he's likely been putting off this visit with the urologist. So now that he's finally presenting to discuss his definitive management, do we really expect him to immediately select the most invasive and body-altering procedure possible, the ileal conduit? And even if he ultimately would elect for and benefit from an ileal conduit, very likely would not be ready to sign up for this treatment right away. Not to mention, if he does not have the dexterity for CIC, good luck having him feel comfortable caring for an ostomy appliance. A suprapubic tube makes a lot more sense for this patient. It will not affect his quality of life in the short term, and it's a temporizing measure which will allow him to consider some other options for the management of his DSD. So what are some of these other options? He can consider pharmacological therapy, sphincteric Botox injections, urethral stenting, sacral neuromodulation, an external sphincterotomy, and yes, an ileal conduit. Placing a suprapubic tube allows us to consider all of these options, keeping an ileal conduit as our backup plan if the less invasive options are not satisfactory. If we go straight to a conduit, well, that's all we get. A common paradigm in medicine is to attempt less invasive treatment options first prior to the more invasive ones, and we should keep this in mind for our patient. Now, should we expect these less invasive modalities to work for our patient? Well, yes, we can. Let's take a look at the data. So for medical management in patients who were started on alpha blockers and with intrathecal baclofen, there were significant decreases in the voiding pressure of these patients, of their mean urethral pressure, their post-void residual, and significant increment in their Qmax. For patients who got sphincteric Botox, there were severe decreases in their urethral pressure and their PVR. What about sacral neuromodulation? Again, significant improvement in their voiding parameters and decreased need for catheterization. And what about an external sphincterotomy? Well, in a study which followed 84 patients who had that operation, 100% of them achieved the primary outcome of not having renal failure at a follow-up of 6 years. All of these options have less morbidity than an ileal conduit, and the morbidity of an ileal conduit can be quite significant. There can be issues with the conduit, issues with the bowel leaks, obstruction, ileus, stomal complications like peristomal hernias, ureteroileal complications such as urine leaks and strictures, infectious and kidney complications such as renal failure, pyelonephritis, and metabolic derangements as well. Urinary diversion is among the most morbid procedures in urology, and these complications, especially the most significant ones, can be very life-altering. So in summary, a suprapubic tube placement is the best recommendation for our patient. It will reliably protect the upper tracts as a temporizing measure. It will allow for the application of less invasive modalities. It does not preclude the utilization of any DSD therapy, including a urinary diversion in the future if that's what the patient wants. And it avoids potential morbidity and issues with dexterity for ileal conduit. Thank you.
Presenting next will be Dr. Yi, presenting the case for urinary diversion.
So our patient is a young 28-year-old man with an unfortunate spinal cord injury 2 years ago and now has resultant PSD. In the next 5 minutes, my goal is to show you that a diversion is the best choice for him because it provides better medical management of his global bladder problem and health, that patients are much happier with diversions than they are with indwelling tubes. And not only is a diversion safe, but it employs the latest techniques and the best of our surgical knowledge. So why is it better medically? The number 2 cause of death in spinal cord injury patients is urinary death. It sounds pretty terrible, and it is. What is that? That's sepsis, septic shock, secondary to UTI, which we all know is very much associated with indwelling catheters. We can avoid urinary death in our spinal cord injury patient with a diversion. We can also prevent decubiti, urethral urine leakage, and perennial skin breakdown, all of which are associated with SP tubes. So most importantly, however, patients with upper tracts that are connected to their hostile neurogenic bladder will develop hydro and renal deterioration over time, even with an SP tube in place. However, a diversion performed properly will prevent this eventual decline in their renal function. An SP tube will not. Patients are happier with diversions, and it preserves their independence where they can apply an appliance at home or have their helpers or caregivers, family members help them change it at their own home. Patients are not happy with tubes hanging out of them, and in fact, they report the lowest quality of life scores on surveys. Not only is diversion durable, but it's safer than it's ever been. This study from my opponent's own institution reports safe and good outcomes of robotic urinary diversions. Not only that, but we have NTREG, ERAS, and advances in PM&R to help our spinal cord injury patients recover from surgery faster than ever before. Papers on complications after diversions are based on open surgeries, long OR times, high EBLs, and those are really becoming a thing of the past. So don't be misled by old and outmoded data. Remember, we were talking about urinary death. That's what we'd be sentencing this young man to if we leave him with an SP tube. According to Katsumi et al., an SP tube is actually worse than his current Foley catheter with more symptomatic UTIs, more bladder stones, and now he'd be leaking out of 2 holes instead of just his urethra. And if you wanted to fix that, he'd need a bladder neck closure, which is often complicated up to 30% of the time. Don't forget about autonomic dysreflexia in these high spinal cord injury patients. As soon as that SP tube is kinked, clogged, or infected, which it will be, you better break out the nitro paste. We'd have to surveil his bladder for squamous cell carcinoma, which is often associated with indwelling catheters. And not only would he be unhappy, but he'd develop eventual renal failure in his lifetime. So in summary, a diversion is better for his global health, renal health, and it will leave him happier than with an SP tube. And not only that, but a diversion reflects the best and most advanced care that we can offer him today safely. And this young man deserves our best. Thanks.
Thank you so much. We'll have 1 minute for the rebuttals.
Well, Dr. Yee has been singing the praises of ileal conduit, but for the visual learners in the audience, I just want to remind everyone of what possibly can happen to our patient, keeping in mind that we have less minimally invasive options available to us. I actually think deep down, Dr. Yee does agree with me. She alluded to this herself in her paper outlining the complications of peristomal hernia after patients who got an ileal conduit. She reported that this was a complication higher than was reported in the literature widely, and that it was a clinically relevant and clinically significant problem. Going straight to an ileal conduit is like shopping in this grocery store. There's only one item on the shelf, and we better hope that we get lucky that we like that one item. Starting with an SP tube and then considering other less minimally invasive options is like shopping in this store. We have a number of options available to us, and we can select the one that most matches our preferences. So it is the clear answer. Suprapubic tube as our initial management is superior to conduit. It'll decrease morbidity, increase our flexibility, and align treatment plan to our patient goals. Thank you.
So you may have heard a lot from my opponent about the safety and the ease of an SP tube, but what about care in the time of COVID? With a diversion, our patient can stay safe and comfortable and independent in their own home with an appliance. Why force him to travel to a COVID-filled medical office for an SP tube change every month? That's almost 400 visits in his lifetime. I don't know if Dr. Slaywin has stock in the Foley business or what they taught him at B school, but why would we be committing this young man to a fate of a 90-year-old with an SP tube? Why aren't we improving the care in the field of urology instead of treating this man with a catheter? Catheters are just the same bad business all the time. We've all seen it, but diversions are the future and better for the patient. So let's do the right thing and not the easy thing for our patient. Thanks.
Thank you both so much. Love the personalization of these arguments. Again, the voting will be down in the lower part, and we'll prepare for our next. And now for our next debate, our first presenter will be Dr. Daniel Rosen, arguing for ablation in this patient with a history of Wilms tumor and nephrectomy.
Thank you. It gives me great pleasure to present at the Michael Droller Chiefs debate tonight, an excuse to wear a suit for the first time in a year, as I argue for ablation versus partial nephrectomy. Why cut when you can poke? Our patient's a 36-year-old woman with a Wilms tumor who had a left radical nephrectomy, right kidney exploration, and chemotherapy as a child. 26, she had a right partial nephrectomy for a T1A clear cell. Now she's got a 3-centimeter lower pole posterior renal mass. What do I hear here? This is a young, otherwise healthy woman with a twice operated on solitary right kidney, with a small renal mass in an ideal location for percutaneous ablation. It's none other than the Black Widow herself, Scarlett Johansson, and she does not want unnecessary scars. She wants oncological control to preserve renal function and minimize morbidity. We have to consider the individual patient in front of us. So she asks you, what should I do, doctor? Which treatment should I get? And you're an honest person. You say, look, treatment works. As long as we aggressively treat this cancer, you're going to be okay. It would be wonderful if there was level 1 data for this lower pole posterior tumor, but it doesn't exist. We can look back at retrospective studies, and sure, I did. There's about a dozen systemic reviews and meta-analyses that apparently we keep writing the same paper over and over again, quoting the same data, some with propensity scores, some with inverse probability treatment weighting. All of them show maybe a 0.1% difference. P equals 0.07, maybe a 4% difference. Eventually, though, the truth is what matters for this patient. There's a greater than 90% chance of success. And if there isn't, and if it does recur, you can treat it at that point at the time of recurrence. And so she said, okay, great. I'm, relieved to hear that. What's the chance that I lose my kidney? I don't want to end up on dialysis. You can, reassure her the risk of conversion to radical nephrectomy from your partial is very low. It's quoted at 3%, maybe 5%. And in each of these studies, let's be honest here, the prediction of conversion is not this patient. Those are hot patients with high renal scores, hilar tumors. Despite the prior surgeries she's had a very low risk of conversion to radical nephrectomy and dialysis. But 3 to 5% is not zero. And so she says, okay, what about the morbidity? And these are both minimally invasive surgery, but complications do happen. In robotic partial nephrectomy, they happen 11% of the time. They're more likely to happen on twice operated on prior chemotherapy patients. While lower pole posterior tumors are ideal for percutaneous ablation, you have the option of offering her a minimally invasive, ambulatory, minimal anesthetic requirement procedure rather than a massive surgery. She doesn't want to stay overnight in the hospital. Hospitals smell. So you could say, wait, hold on. There's a complication rate for percutaneous ablation as well, 3 to 7%. It's less, but it's still there. But usually, if you look at this data, it actually shows that complication is usually just hematuria. We know how to deal with hematuria. And if she obstructs, we could put in a stent. She's not going to lose her kidney. This tends to occur in large central tumors. That's not this patient. You say, well, what about bowel injury? I've seen that before. No, that's an anterior tumor. It's not this patient. Pneumothorax, that's superior. Not this patient. This patient has a lower pole, posterior, non-hilar, 3-centimeter tumor with prior surgery, making surgery a higher risk. She's the ideal candidate for a percutaneous ablation, and that's what you offer her.
Thank you. And then up next will be Dr. Nikhil Gopal presenting the argument for partial nephrectomy.
Okay, good evening, New York AUA section. I hope to convince you over the next few minutes that partial nephrectomy is the best choice for this young female with a solitary kidney and recurrent renal mass. The latest AUA guidelines clearly show a preference for partial nephrectomy. Here, partial nephrectomy is recommended as the intervention of choice in management of T1A renal masses, while thermal ablation is relegated to an alternate approach for T1A lesions less than 3 centimeters. While many recent studies, like my opponent showed, demonstrated equivalent oncological outcomes and improved rate of perioperative complications in patients undergoing ablation versus partial nephrectomy, it's important to consider some of the flaws of these studies. First, none of these studies are randomized controlled trials, and therefore there's the potential for significant selection bias. For instance, patients in the partial nephrectomy group may have increased tumor size or a higher nephrometry score that may by themselves lead to increased perioperative complications. So without RCTs, we have to look at propensity matched cohort studies. And unlike my opponent, I actually looked at a propensity matched cohort study specifically in patients with a solitary kidney, either undergoing percutaneous cryoablation or partial nephrectomy. In this study, the only difference seen after controlling for features such as age and comorbidities was actually worsened overall survival that you see in red. There was no difference in post-treatment complications. Another cohort study showed a 2-year recurrence-free survival that was lower in patients undergoing ablation. So from these propensity matched studies, we actually see evidence for inferior oncological outcomes in patients undergoing ablation. Indeed, as cited in the AUA guidelines, patients should be counseled about increased local treatment failure with ablation. It is well established that local recurrence rates after partial nephrectomy are about 1 to 2%. In contrast, a local recurrence rate after a single ablation session is 6 to 7%, with 2/3 of all recurrences due to incomplete tumor ablation. In the event that tumors don't respond to ablation, performing subsequent partial nephrectomy is associated with significant complications, as these 2 recent studies show. So in the absence of strong data supporting the oncologic equivalence of thermal ablation as opposed to partial nephrectomy, one still might be tempted to offer this less invasive option because this patient had a previous partial nephrectomy and a previous right kidney exploration. However, there are recent clinical studies here showing that there's equivalent perioperative complications between initial and repeat partial nephrectomy. In terms of renal function, while there may be acute renal insufficiency secondary to ischemia-induced clamping in a solitary kidney after partial nephrectomy, multiple studies have demonstrated this kidney injury is reversible in the long term, with no long-term difference seen in renal function between ablation and partial nephrectomy. So in conclusion, partial nephrectomy is the gold standard for management of localized renal masses. It has the benefit of robust evidence of its efficacy, including a randomized controlled trial against radical nephrectomy with a long follow-up time, which cannot be said for ablation. Not only is partial nephrectomy safe to perform in a previously operated kidney, there is no increased risk of long-term renal insufficiency, even in a solitary kidney, and it has a reduced chance of local treatment failure. This patient is not a 70-year-old with CHF and COPD, as are most of the patients in the ablation cohorts. This is a 36-year-old, otherwise healthy female who, likely through genetics, has recurrent localized kidney cancer. It is our obligation as urological surgeons to give her the gold standard. We don't poke, we cut.
Thank you, and we'll have 1 minute for rebuttals.
Thank you. So as we push the envelope, we should ask, are we already there? Yeah, we can do a minimally invasive ambulatory drainless third operation on a solitary kidney, but do we have to when we have a better approach? We've seen this advance. And I'd like to admit, robotic partial nephrectomy is very good. It's a great procedure, but no surgery is even better. Dr. Gopal brought up what he called the gold standard of approaches. But I'd note two things. One, we haven't used the gold standard in the United States since 1973. Two, in order for something to be better, it needs to actually truly be better. When you look at a study that shows overall survival is improved, but cancer-specific survival is not, you've got to worry about selection bias. Let's consider this individual patient. A randomized study doesn't exist. We have an option of a low-risk, minimal anesthetic requirement, outpatient effective treatment versus a high-risk adhesion-filled nightmare. So what happened to our patient? Well, it's New York City. She was seen by 3 different providers at Mount Sinai Sloan, 2 other institutions. Ultimately, she opted for active surveillance till next year's AUA New York section chief debate. Thank you.
Okay, so my opponent keeps mentioning that ablation is a minimally invasive option, but I just want to highlight that it is an intervention and does have real risks, such as a perinephric hematoma, a urinoma with renal pleural fistula, and bowel injury. And these patients will have to stay for longer than just the same day. In addition, there's as seen on this CAT scan, there's the risk of persistent contrast enhancement with associated treatment failure. So as I said before, repeat partial nephrectomy is safe, it's more definitive than ablation, and it's not associated with long-term renal dysfunction. This young patient deserves the most definitive treatment that will maximize her chances of living cancer-free with a good quality of life, not just for 1 or 2 years, but for the next 40 years of her life. There is only one treatment with that type of follow-up, especially in patients as young as this one, as seen in the experience with VHL. Localized renal cell carcinoma is a surgical disease, and we as urological surgeons would be best served continuing to treat it that way. Thank you.
Thank you both. Additionally, just wanted to point out big congrats to our hardworking residents. Dr. Gopal is in his call room giving his presentation from work. So we appreciate that effort. Also, I know residents don't get paid that much, but I think everyone could invest in a good ring light, it seems, today. And now for our next debate, Dr. Matthew Smith will be presenting robotic radical prostatectomy for our patient.
Good evening. My name is Matthew Smith. I will be arguing for radical prostatectomy. I will be winning on behalf of SUNY Downstate. All right, so you know the prompt. It's a 55-year-old gentleman. He has PIRAS 4 lesion, 3+4 prostate cancer, and he's extremely concerned about his erectile function. I am too. So what do I recommend? I recommend science, research-proven science, not feelings, not well wishes, not likes, not thoughts and prayers, actual science. Don't get me wrong, focal therapy is cool. It's like a cute idea. I like it. I also like cookies, warm, gooey cookies. Sometimes when I'm baking cookies, I get a little impatient. I don't feel like waiting for everything to get done, and I just take the cookies out of the oven soon. It's not a problem because I also like cookie dough. It's weird that I have to say this, but prostate cancer is not a cookie. You can't just treat cancer however you want because you don't feel like waiting for the data to come through. You have to do the studies. You have to look at the long-term data. We have been saying the exact same thing since 2007. And yet, I did a prostatectomy yesterday. My opponent did a prostatectomy last week. Why? Because they have not done the correct study, the real study, the randomized controlled trial that shows me and you and everyone else which modality is actually better, or that neither is better. Even if you could just show me that like focal therapy was non-inferior, like almost as good, that'd be one thing. You don't know. You haven't done all the studies. Until you do, you don't talk to them. I don't remember how many of these I have, but I think you guys get the point, right? There we go. All right, so I'm confident that in the future, we will not be treating the entire prostate. That's fine, but today is today. And today, men have prostate cancer. And you cannot look your patient in the eye and honestly tell them that you know what's gonna happen after your treatment. We think it's better for erections, it probably is. We think it gets the cancer, it probably doesn't, at least not after the first shot. We think it's a good option, but we don't know. That's okay. We need to find out, and we can do the study together. But until then, for the people who have cancer today, you can come to my hospital, I will do your prostatectomy, and if you have problems with erections, I'll handle that too, because I am your doctor and I use science. Thank you.
Thank you. Up next will be Dr. Joseph Sarcona arguing for focal therapy.
Good evening. Before we start, I want to thank the New York AUA section, Dr. Cavussi, our judge and host, Dr. Sue and Dr. Kreshover, and all of my fellow graduating chief residents participating tonight. Tonight, my colleague and I have been asked to argue that the best treatment option for our patient, and I am here to tell you that focal therapy is that best option. Our patient, he's 55. He's at the peak of his life. He's very physically and sexually active, and he was very concerned when his PSA came back at 5. He got a prostate MRI. It showed a solitary 12 millimeter PIRAS 4 lesion, right mid gland. MRI fusion biopsy showed grade group 2, 3+4 prostate cancer only in the MRI lesion. That's it. All the other cores were negative. Our patient's goal, a treatment goal, is strongly centered around maintaining quality of life, especially sexual function. During your initial visit, you go over the USPSTF slides. Oh, these are my old slides. It's okay, we'll make it work. That show for every 1,000 patients that undergo PSA testing, around 100 ultimately will undergo biopsy, 80 of which will be treated with radical therapy, up to which 60% will have erectile dysfunction, around 18% will have urinary incontinence. And it's not showing here because the slides got mixed up, but there's hundreds of ads in New York City for IPPs. And the reason is for things like this. So what are our options when we're talking about low intermediate risk prostate cancer? Typical treatments, radiation treatment of various modalities, surgical treatment, MIS typically performed robotically, and focal therapy. What is focal therapy for those that don't know? It's just that, treating less than the whole gland with various modalities, most common being HIFU, cryotherapy, as well as novel laser ablation and other novel treatments, all of which become more focal as MRI fusion technologies become more advanced. In the world of focal therapy, a parallel has often been drawn between prostate cancer and breast cancer. Breast cancer used to be treated just like this, like with radical therapy. And over time, data-driven change, first based on the American Journal of Clinical Oncology article in 2005, has led to lumpectomy plus or minus chemoradiation becoming the standard of care because it adequately treats the primary tumor while minimizing side effects. Prostate cancer is basically the same. It's a good candidate for focal treatment because of the concept of the index lesion described by Stamy and colleagues in 2001 European Urology article. They showed through whole mount pathology that although often multifocal, biochemical recurrence is related to the primary lesion and not determined by secondary cancers within the prostate. It's easy to say, it's easy to have very few side effects if you're not really treating cancer, which I agree with, but focal therapy aims to hit the ideal of treating cancer while minimizing side effects. On the left, you can see a 5-year outcome study for HIFU where they looked at 625 patients, 85% of which had intermediate high-risk cancer for over 5 years. Their failure-free survival was 99% at 1 year, 92% at 3 years, and 88% at 5 years, with a metastatic-free survival of 98% at 5 years and cancer-specific survival 100% at 5 years, comparable to a robotic prostatectomy. Importantly, they had a 98% pad-free urinary continence rate. And on the right, we see that IPSS scores and IEAFF scores also are basically not statistically different. Though there are no randomized comparisons between focal therapy and radical surgery, I admit, a 2017 article compared matched cohort of HIFU, hemiablation, or robotic prostatectomy. It showed no difference in need for salvage, external beam radiation therapy at 5 years, and a quicker recovery of urinary continence in the focal therapy group. And for our patients specifically, better potency rates at 1 year, 83% versus 38% in favor of focal therapy. So I know what you're saying about the data, but the data's there and it's getting better every day. Thank you.
All right. Thank you, Dr. Scarpato, for quoting a bunch of short-term studies, some of which came out when I was in the 8th grade. Let's do some questions from your actual patient. So, hey, doc, are you sure you can get all the cancer? I don't know. Clinical significant, I mean, prostate cancer is multifocal, so we'll just get the big one and hope you're good. Well, how would you know you got it? I don't know. We'll get some PSAs. We don't really know what that means. Then we'll get an MRI or two. We don't really know what that means. So then we'll just rebiopsy, and up to half of those can be positive. So then we'll just zap it again or freeze it again or laser it, whatever happens to be paying the most at the time. So what about that HIFU option you were mentioning? So I know you quoted one study where nobody had salvage prostatectomies. There's another one where up to 20% had to get one at the 1 year mark. But I'm sure you really like doing them in between Urolifts, so we'll just do that instead. Well, damn, doc, what would you do? Me? I'm gonna be on active surveillance until it's time for me to get my actual surgery. I'm not gonna be some guinea pig, but it's perfect for you. At the end of the day, you need to have a randomized control trial. There is excellence trials coming through, but until then, do the right thing. Thank you.
So my colleague here spoke to you about the benefits of radical prostatectomy and how focal therapy is considered some experimental treatment. But let's look at the facts to see how good prostatectomy even is. We have the PIVOT trial and the PROTECT TREE trials, which gave us insight into the progression of prostate cancer. PIVOT showed no difference in overall disease-specific mortality between observation versus radical prostatectomy, and the PROTECT T trial showed no difference in prostate-specific mortality in active surveillance versus surgery versus radiation. Our new data out this past month also shows that should patients recur, salvage prostatectomy in patients receiving focal therapy have much better outcomes compared to other radical modalities. And we need to remember, robotic prostatectomy has side effects, even in the best of hands. Although it has been written throughout the years, many ways, 2015 European Urology article showed a 21% incontinence rate and a 70% erectile dysfunction rate, though they didn't mention specifically the preoperative ED rates. Ultimately, we need to treat our patient as individuals. Our patient's biggest goal is quality of life and maintenance of sexual function. We currently have a treatment that is efficacious, has cancer control much better than active surveillance, and has less side effects than a robotic prostatectomy. Ultimately, sure, maybe the best prostatectomists have low impedance rates, but this guy, he isn't an experienced robotic surgeon. He's a first year attending right out of residency, and the best option for our patient is focal therapy.
All right, thank you both. Again, there's voting below. Put in your thoughts and we'll move to our next topic. Multiple points of contention for this next question. Presenting first will be Dr. Ethan Fram, who argues to take the patient to the OR tonight.
Thank you. So I'd like to thank everybody for this opportunity to explain to you why you must treat an emergency case as an emergency. So we're going to start off by introducing Brian. Brian is our young boy who has come in with a testicular torsion, confirmed to be ischemic since this afternoon, and possibly before, but definitely since this afternoon. So I'd like to remind all of you that time to detorsion is directly related to the odds of salvage in this. And at this point, we know that he has been ischemic for hours. So any sort of further delay greatly increases the risk that he is going to suffer an orchiectomy, or even if we are successful in detorsing him, suffer atrophy over time. Now, this has been well established in numerous observational studies. And in my literature review, I wasn't actually able to find anyone brave enough to do a controlled trial on this, which I think really speaks to the overall agreement that this is an emergency. Even during the current pandemic, this is not considered to be an acceptable reason for delay. So if you're looking for an out during these exceptional times, multiple guidelines from multiple major international organizations have agreed that this is not an acceptable reason to delay. Now, we're talking about a child here. Brian is young. He has a long life ahead of him. And without that other testicle, he does have some increased risk. He's pre-pubertal, presumably at his age. So having a torus testicle can affect his ability to produce adequate hormone. He may have a problem with the other testicle. This may be costing him his fertility if we are unable to save this testicle. And not to mention, boys can be pretty cruel in junior high, and going through with only one testicle is not going to be a pleasant experience. I couldn't find a citation for that, but I did go through junior high. Testicular torsion is a surgical emergency. This is not something to sit around. This is not something to say, well, my colleague might be able to do a better job of this. Sure, in 8 hours, maybe, assuming that they allow you to bump yourself for the operating room and that it doesn't go the next evening. This is a well-established thing. As we alluded to earlier, our Bible does say that you need to get these patients to the OR as soon as possible. It is well established. This is a true surgical emergency. It is a time-critical need for surgery. And that's the main predictor is how often you get them to the operating room, whether or not they're going to have outcomes. Now, I will note that even if you are as heartless as I suspect my opponent to be, and you don't care about the outcomes for the patient, there is a significant medical legal risk in not treating this appropriately as an emergency. This study retrospectively looking at malpractice cases in urology found that about 50% of these will settle either in favor of the plaintiff or with a pre-trial settlement. So you're flipping the coin when you decide to delay on this case. Now, our prompt, you are 10 years out of fellowship for FPRMS, so congratulations, you've subspecialized, you presumably are doing really great things, but you've agreed to take pediatrics call, and presumably you must be prepared to handle one of the most common pediatric surgical emergencies if you have agreed to take that call. So I don't want to say that you're an incompetent individual. You've agreed to take it, therefore you must be competent to do this. And I don't think it's appropriate to delay in time to allow the pediatric urologist to handle it in the morning, almost 8 hours later, if we're assuming, a 7 a.m. start time. So I'd like to thank you all for listening to this introduction, and I'm very interested to see how my opponent is going to try to justify delaying this very clear indication for immediate surgical intervention.
Thank you, Dr. Fram. Up next is Dr. Zach Kozel arguing the opposite, to admit the patient and refer to the pediatric urologist in the morning.
Hello, I'm Dr. Kozel, a chief urology resident at Northwell Health. I'm going to tell you why the right thing for our patient is to admit him and have him evaluated in the morning by the most appropriate specialist. So meet Bryce, or Brian as my opponent said. So he's an 11-year-old male with right testicular pain which began 3 days prior. Now, 3 days after initial presentation, he underwent a scrotal ultrasound, which demonstrated no flow to the right testis, and then went to the ER for evaluation. Now, he's in Ethan's ER 72 hours after symptoms began, looking for treatment. And shockingly, I'll agree with my opponent. Testicular torsion is a surgical emergency, acutely. However, testicular salvage, as my opponent expertly outlined for me, is a time-dependent phenomenon. And numerous studies have shown that rate of testicular salvage 48 hours after symptom presentation is approximately 0%. So on this graph by Pogorelic et al., my opponent thinks we're over here in the initial stages of presentation when minutes and hours are crucial to salvaging that testicle. However, we were here. However, we waited. Bryce played some Fortnite. Bryce took a nap. Bryce took another nap. And now we're over here in reality, over 72 hours after initial symptom presentation, where we can see that the rate of testicular salvage has flatlined and is now 0%. So my opponent will say, okay, maybe it doesn't have to be done tonight, but let's do it tonight. You know, I have a flight to catch in the morning and I don't want to be delayed. I'm trying to get there as soon as possible. Cancun's very nice. And I'll say, there's a reason why we do elective cases during the day. Numerous papers by Kells, Turrentine, and Whitlock have shown that elective cases performed at night are associated with increased complications, higher rates of return to the OR, increased length of stay, and even increased mortality. With these findings leading experts to recommend that when we can, we should delay surgical cases to the following day to achieve the best possible outcome for our patients. And my opponent will say, fine, okay, we don't have to do the case tonight. We shouldn't do the case tonight, but listen, I've had a hard time. I bought into GameStop and, you know, I didn't really sell when it was high. I had paper hands and now there's rebounding. I have nothing to hold on to. So can I at least please do this case? And I'll say no. There's a reason why specialists exist and people can be jack of all trades and experts of none. When we're looking at low volume urologic surgeons in a paper by Nguyen et al., we can see that comparing them to high volume surgeons, low volume surgeons have longer lengths of stay and higher rates of surgical related complications, like this nasty hematocele here, leading Ethan to have this kind of expression. Additionally, papers by Kokoskik et al. Have shown that pediatric fellowship is also associated with decreased complications and decreases length of stay following routine surgery. So to sum up all these findings, in conclusion, it doesn't have to be done tonight as it is no longer an emergency. It shouldn't be done tonight because doing nighttime surgery when you don't need to increases your mortality and your morbidity. And finally, it should be done by an experienced specialist because that can achieve the best outcomes for our patient here, Bryce or Brian. So that's why the right case is to have Brian evaluated by the most appropriate specialist in the morning now that this is not an emergent case.
Very good, Dr. Colson. That's to listen to the response. Applause.
Well, I couldn't hear you guys applaud. I assumed you would, so I put it in for myself.
All right, and we will have 1 minute for the rebuttals next.
Well, I'd like to appreciate points that my opponent made. So my opponent made a couple of points. The first is that he claims that this patient has been ischemic for 3 days straight. We don't know that. That may be true, but until we actually look at that testicle, the only thing that we know is that he's been ischemic since the time of that ultrasound that was performed. And while I agree with my opponent that yes, emergency surgeries are emergencies, they are more likely to have complications than elective surgeries. The data that he presents to support the increased risk of nighttime elective surgeries is not actually from pediatrics. And if you look at the citation, they're actually based on general surgery cases done at VA hospitals and adult patients. I would ask you, could you consciously say that we're going to wait on this patient, guaranteeing that this testicle, if it was viable, is no longer going to be viable just because I want a pediatric urologist to be the one to do the orchiectomy? Could you really sleep with that? So thank you for listening.
So we've heard from my opponent. He once again stressed the importance of the ultrasound as establishing the time point of ischemia. However, we know from that same Bible he's referencing, testicular torsion is a clinical diagnosis which should be able to be made by good clinicians. So we know when we talked about his initial exam, we can establish a relative time point for his ischemia. So this is not an emergent case. It was an emergent case 3 days ago, which we can see by the graph. Again, my opponent will stress that the physician on call should be able to handle this. However, can doesn't mean have to or should. And I've shown that both timing and specialty training impacts outcomes. So we need to do the best we can to afford the best outcome for our patients. So the combination of the emergent nature, the timing, and the specialty training having impacts upon the surgery is why I say good surgeons, like my opponent, know how to operate. Better surgeons, like myself, know when to operate. But the very best surgeons, like our esteemed judge, know when not to operate. So do the right thing, admit the patient for this non-emergent issue, and have them evaluated by the most appropriate specialist in the morning.
Thank you both. Voting again is below in the chat box, and we will move on to our second to last question. So our next presenter is Dr. Kirsten Craig. She'll be presenting the simple nephrectomy in this patient.
Thank you. Thank you for the opportunity to discuss my patient, Sophia. This is Sophia. She's an 87-year-old female with advanced dementia and recurrent UTI complicated by sepsis. She was found to have a non-functioning hydronephrotic right kidney, which was temporized with a PCN tube, which unfortunately just 2 weeks later resulted in a dislodgement of that PCN tube, which will require replacement by interventional radiology. This is her daughter. She wants to give her mom the best quality of life. Now, Dorothy recently heard of the untimely death of Tanya Roberts due to a urinary tract infection with urosepsis, and she's scared of the ultimate results that were happening to her mom. Here's a Lasix renal scan showing an obstructive right kidney with hydronephrosis to the level of the UPJ. As we know, these are most commonly due to crossing vessels, but also could be due to an aperistaltic ureter. Her kidney is non-functional, which by definition has at most 15% function. As we know, the PCN tube may be the appropriate treatment for an acutely decompressing of this obstructive pyelonephrosis, and it will provide temporary relief, but nephrectomy is the best definitive management of this patient. The nephrectomy is a single intervention that removes a source for her recurrent infections. The patient and her daughter have prioritized quality of life. Do you think they want to go to the hospital every 3 months and risk exposure of COVID for these PCN exchanges? Plus, each time she pulls out the PCN tube during her less than lucid intervals. The PCN is a foreign body open to the world in a system that is already prone to infection. Dr. Sterling will argue that anesthesia is high risk in this woman with advanced dementia, but her dementia also makes frequent exchanges difficult, possibly requiring sedation and urosepsis from a colonized PCN tube, which is a bigger risk in this patient. And so I ask the audience, in this 87-year-old female with a non-functional kidney and recurrent UTI demonstrating a propensity to pull out the PCN tube, what is the definition of insanity? I'll leave Dr. Sterling to let you know.
Thank you. And up next will be Dr. Joshua Sterling arguing for continued nephrostomy tube and observation.
Alexander Pope wrote, "To err is human, to observe is divine." At least I think that's how that poem goes. My name is Joshua Sterling from Rutgers RWJ. Thank you for having me here tonight. Let's meet Grandma. She's an 87-year-old female with late-stage dementia, but clear advanced directives which her family has reiterated. The most important thing to them is quality of life. The patient has a recent history of recurrent urinary tract infections requiring hospitalization and was subsequently diagnosed with severe hydronephrosis in a non-functioning kidney. The patient had a nephrostomy tube placed 2 weeks ago during her last hospitalization, which was traumatically removed and now needs replacing. So what do we do? The Hippocratic Oath states, "Whatsoever house we enter, we will enter for the benefit of the sick." We are not here tonight to have an academic debate about nephrectomy versus observation. We are here tonight to discuss providing the best possible care for this particular patient. Remember, we work on behalf of our patients. I could cite any of the 40+ manuscripts on bioethics and surgery published in the first 2 months of this year alone, or we could just review basic concepts we all learned as first-year medical students. Yes, both options can provide benefit to the patient and both will consume potentially scarce resources. The pillars of justice and beneficence do not influence our decision either way. The patient and her family have exercised their autonomy and expressed their wishes. The concept of non-maleficence states that a medical practitioner has a duty to do no harm or allow harm to be done to a patient through neglect. And while we can and will debate an nephrectomy's potential for harm, it would be 100% incorrect ever to equate observation with neglect. Yes, we are all surgeons in our places in the operating theater, but as Uncle Ben said, with great power comes great responsibility, and no surgery is a benign act. So what is the risk of complications with a nephrectomy? Here's a series of 154 patients that found 7.6% of patients had complications after nephrectomy for benign reasons. They reported a 30-day mortality of 1.3%. The mean age in the benign cohort, 32. Even in young, healthy patients, there is a very real risk of complications. Maybe you don't trust the editorial rigor of the Journal for the Pakistani Medical Association. Do you trust the Mayo Clinic? They looked at 285 patients receiving radical nephrectomy for benign and malignant reasons over 4 years. They reported a complication rate of 15.6%, 4% conversion to open, and while they reported 0% mortality rate, 35% of the patients included in this study were donor nephrectomies, arguably the healthiest of surgical patients. We could talk about robotics as the way to go. The Brady Urologic Institute at Hopkins published a comparison of robotic and laparoscopic outcomes in 2016. The only two differences, robotic nephrectomies had a higher incidence of conversion and cost more. We can even talk about the risks of this procedure in octogenarians, but the only risk that matters to this family is the risk to this particular patient. NISQIP estimates that grandma's risk of serious complications, assuming that her only other medical, she has no perfect health other than her dementia, is 5%, but her risk of functional decline is 49%. In other words, in the best case scenario, it's a coin flip that grandma doesn't wake up the same. When faced with difficult decisions, I try to follow my grandfather's advice. Keep it simple, stupid. Simply put, grandma has 3 problems in one wish. Yes, a nephrectomy will address the urinary stasis and infections, but likely doesn't jive with grandma's dislike of tubes, and who knows what it'll do for her quality of life. But there is another way, a simple way. Observation is not inaction. We should insert a metallic stent. They have excellent patient tolerability, are exchanged annually, and decrease grandma's annual healthcare costs 43% compared to traditional nephrostomy tubes or ureteral stents. As for the recurrent infections, we can start grandma on Hiprex, which is proven effective in elderly patients regardless of their kidney function and can reduce the frequency of UTIs up to 400% without increasing antibiotic resistance. Thus, we solve all of grandma's problems and ensures she maintains an excellent quality of life.
Thank you both, and we'll get prepared for our rebuttals, each of your rebuttals.
Dr. Spencer argued that age made nephrectomy a suboptimal choice in this patient of an advanced age with dementia. But I let the words of our own esteemed judge speak for themselves in this study published in Urology in 2002, which showed that the elderly population were even a suitable candidate for a donor nephrectomy in the elective setting. Don't believe our judge? Let's look at my version of the NSQIP, which for our healthy grandma does not show a series complication or any complication that's higher than the median risk. It does show the increased postoperative delirium, functional decline, and new mobility aid use. But for the PCN, it doesn't even look at the elderly population. It looks at the PCN tube removal and not the placement. And we haven't incorporated the anesthesia that's necessary for this demented patient who's going to require sedation to have these multiple tubes replaced every 2 weeks from the first presentation of this patient. Thank you.
This case brings to mind an axiom that's already been mentioned once tonight, that a good surgeon knows how to operate, a better surgeon knows when to operate, and the best surgeons know when not to operate. My respected colleague and her venerable institution are frequent contributors to the lay media in their noble attempt to get sound medical advice out to the masses. So I find it curious that while she is advocating for holistic medicine for the treatment of stones, she's advocating for holistic medicine for grandma. In this scenario, I think we can all agree that the best option is just give grandma a kiss. Let's cancel the nephrostomy tube. Let's insert a metallic stent, start suppressive medications, and most importantly, let's see grandma next year. Thank you.
Thank you both. As a reminder, you can vote below FYI, you're supposed to vote for who you feel like gave the best argument, not necessarily who you agree with. In this instance, I did take the patient to the OR and she left on post-op day 1. For our last presentations, our first presenter will be Dr. Tejas Shah, who will be presenting laparoscopic nephrolithotomy with ablation of the diverticulum. Take it away, Dr. Shah.
All right. So here we have patient Anthony Fauci, 73-year-old male who's been through a lot in the past year, namely COVID and dealing with an incompetent administration and its associated bureaucracy. He's been stressed and having a lot of sleepless nights while trying to navigate this unprecedented pandemic. But now he and the country are finally seeing the light at the end of the dark COVID tunnel, as long as these variants behave. Vaccines are being rolled out, cases are dropping, and the new administration and public are finally listening to him. As things get better, he really needs a vacation and just wants to travel, safely, of course. Unfortunately, he's been dealing with recurrent UTIs and recently found to have a 2-centimeter dense stone in the lateral mid-pole calyceal diverticulum. He's on Brilinta for AFib and a history of stroke. I'm going to tell you why he should unequivocally undergo a laparoscopic nephrolithotomy, an effective one-and-done procedure which will allow him to go on and enjoy a much-needed vacation. In this 2014 paper from the Arthur Smith Institute, they reviewed 8 studies with a total study size of 17 patients. Most importantly, they found stone-free rates to be 100% after laparoscopic procedure, and symptom-free rates also to be 100% with a follow-up of 2 years. Furthermore, only 2 of 17 patients had any complications, with 1 patient requiring a blood transfusion and 1 patient having a very minor complication of subcutaneous crepitus. Also, the studies reported 66 to 100% stone obliteration of the diverticulum. This data strongly demonstrates that a laparoscopic approach has a very high stone-free rate and would be an ideal one-and-done procedure for this patient. In the same paper, they reviewed 18 studies which looked at PCNL for stones in calyceal diverticulum, and without a doubt, the outcomes strongly favor a laparoscopic approach over a PCNL. For PCNL, reported stone-free rates were as low as 69%, symptom-free rates as low as 77%, complication rates, major or minor, were significantly higher, anywhere from 10 to 54%, and TIC ablation rates as low as 19%. Without a question, a laparoscopic approach would provide significantly better outcomes for this patient. This 2017 study was a meta-analysis looking at laparoscopic versus a percutaneous approach, a total of 901 patients with almost an even split of laparoscopic and PCNL patients. They found that compared to PCNL, laparoscopy provided significantly higher stone-free rate, lower blood transfusion rate, lower bleeding rate, fewer hemoglobin decrease, less postoperative fever, lower auxiliary procedure rate, and lower retreatment rate. Don't let my opponent fool you, spew his fake nonsense. Clearly, a laparoscopic procedure is far superior approach for this tired, valiant patient who just needs a break. He deserves a one-and-done procedure, a laparoscopic nephrolithotomy and ablation of TIC, which will provide safer and superior outcomes. Thank you.
Thank you. And presenting the PCNL with ablation of the diverticulum would be Dr. Edward Forsyth.
Well, everyone, I'm Edward. Thank you for having me. It's an honor to be here, and thank you for still watching towards the end. So we're almost there, and bear with me. So I too, like Dr. Fauci, and I want to help him, and I don't want to experiment on him. So I want to give him an ideal procedure, effective, safe, supported by data, and less invasive. Now, a very effective procedure was invented a long time ago, but it happens to be quite morbid and quite invasive. So we often turn to technology in times like this. Smaller incisions, laparoscopic cameras, and we'll go to the next step. The robot is here, higher articulating control, and maybe here in the middle, a single port robotic surgeon. Let's get it done with one single incision. Actually, we've been doing that for years. The ideal minimally invasive procedure has already been in use, and it's the PCNL. Let's not forget that Dr. Fauci is on Brilinta, which significantly increases his bleeding risk. So let's compare the bleeding risk between the two procedures. PCNL, 1 incision, laparoscopy at least 3. PCNL, you won't be dissecting the hilum, but if you're going to be mobilizing the kidney in order to possibly clamp it, you're going to have to mobilize and maybe clamp the hilum to stop it from bleeding. There's no dissection of the kidney for PCNL. You're going to be mobilizing it to find the diverticulum if you're going to do laparoscopy. To get in, you'll be dilating a needle tract with PCNL. Laparoscopy, you're going to have to incise the parenchyma. I'm talking about an 8 to 10 millimeter incision. If you're going to take the stone out and it's a 2 centimeter stone, you're going to need at least a 2 centimeter incision. What happens if we do encounter intractable bleeding? For PCNL, you might escape by leaving a large nephrostomy tube and placing a balloon and get them over to IR for an arterial embolization. For laparoscopy, you'll clamp the hilum if it's already available for you and perform a rhinorrhaphy, or worst case, convert to open, or even perform a nephrectomy. Which of these complications looks bloodier to you? The needle or the way open incision? So Dr. Okiki is a famous endourologist and member of this New York section. And while my opponent astutely noted that they compared laparoscopy to PCNL, you really need numbers if you're going to show a good effect. So 17 laparoscopic cases versus 349, you might encounter more complications when you're doing a much higher volume of a procedure. Their conclusion, laparoscopy should be reserved for cases with stones in anterior diverticula with thin parenchyma or that are refractory to other treatment. In other words, not our patient. In the systematic review in 2018, they compared PCNL to ESWAL. Well, where's the laparoscopic data? The literature on laparoscopic management was too sparse to analyze. Dr. Gupta is a famous endourologist and member of the New York section, and he did over 1,000 PCNLs and encountered this rare case over 50 times. 96% were stone-free with the diverticulum ablated, 100% resolution of symptoms, no bleeding complications. 64% were even in the anterior diverticulum. There was a few cases of needing to retreat the stone that they performed ureteroscopically without complication. Conclusion, percutaneous management is safe, effective, regardless of stone burden, diverticular size, or location. This is our patient. Thank you very much for having me.
Thank you both, and we will get prepared for our final rebuttals.
All right, so my opponent may have had a nice little table there, trying to convince you that PCNL is less invasive, but let me show you some facts. This is a meta-analysis, and you can see that PCNL has significantly higher blood transfusion rate compared to laparoscopy in this study. For a patient already with cardiovascular and cerebrovascular compromise, needing a blood transfusion can lead to further impairment and complications. More data, and not just the table. PCNL also has a higher retreatment rate. Why would you subject a patient on anticoagulation and with a history of stroke to possibly needing a second procedure and therefore requiring additional time off anticoagulation, which can lead to increased risk of peri and post-operative cardiovascular, cerebrovascular events? Our patient's been able to survive COVID and an incompetent administration. Don't let multiple suboptimal procedures be his demise. There's only one correct choice, the one and done procedure, a laparoscopic approach. Thank you.
Thank you, Dr. Shaw, and we'll get Dr. Forsythe's rebuttal.
I'm so happy Dr. Shaw brought up bleeding risk. Now, I'm sorry that you all have to see this. It might be hard, but we should remember that laparoscopy also has bleeding risk. And I don't want to watch this anymore because it makes me sick looking at it. So let's go on to our own guidelines. There are 2 citations that address a stone and a calyceal diverticulum. Why don't we look at the conclusions of these 2 papers? Laparoscopic surgery should be reserved for cases with large stones, thin overlying parenchyma, and cases refractory to other treatment. The second, the conclusion is PCNL is effective and durable means of treating calyceal diverticular stones, regardless of stone size or location of the diverticulum. Really, there's only one choice for Dr. Fauci, who I'm also a big fan of. And thanks again, and you made it, everybody. Congrats.
Thank you both. So we'll complete the voting down below. You'll give us a minute and we'll come back and Dr. Su will give his thoughts for each of the presenters, who won, and I will let everyone know who the audience picked as the winners. Welcome back, everybody. We have Dr. Su will present for us his comments and his winner for our first debate with Dr. Caputo and Dr. Billa.
Before I get there, I just want to thank Dr. Kreshover, Dr. Cavusi, and the New York section membership for giving me this opportunity. I certainly wish I was in New York with you all. I certainly miss my days back in the 90s when I was there for medical school and then residency training, spending a decade of my life there. I certainly have great memories. Also want to thank the organizers, especially Michelle Paoli, as always, for doing such a wonderful job and helping us get our Zoom straight, and Michael for his excellent AV work. And lastly, I want to really congratulate the residents. I mean, this was a fantastic session. It really brings me great thought as to maybe how we can improve our Southeastern section and employ very similar competitions to encourage our residents to learn the importance of public speaking. I also want to thank the mentors for spending time with them. You know, when I think about this, and we spent a lot of time with our residents at our institution thinking about public speaking, and this is probably one of the most important things that we can do for our residents and our trainees. You know, as per instructions, I was supposed to not choose what I would do, but really think about the presentation itself. And so I think about certain measures of abilities and presentation styles. I think, you know, there's certain principles. One needs to be very enthusiastic and use inflection of your voice. You know, clear use of slides and figures are very important to demonstrate your knowledge base and the evidence behind your argument, but being careful not to make them too cluttered and too busy so as to lose the point of your argument. Ultimately, you need to tell a story. You need to bring the audience through an entire journey to be ultimately very compelling about your argument. You have to be adaptable and a very good listener so that you can reply or respond to your opponent. And that is one of the most tricky parts of this. But I want to congratulate all of you. I think you guys did a wonderful job. So the first debate, very good start. I enjoyed hearing both individuals, Dr. Caputo and Dr. Bilal. I think that, you know, certainly very different styles and different approaches. I think the delivery was good on both. For Dr. Caputo, just some pointers. I think you had a great delivery, great visuals. You know, I would say I would be careful about stacked slides. I think sometimes it gets a little too busy and hard for the audience to follow, but you had a great presentation style. Dr. Bilal, I think that you took the more comic approach, and I think that it did have quite a good response. I think the audience probably resonated a lot with your particular style. Although you did lose me with the Trump slide, so I just will, I'll try to stay apolitical here, but I will have to say that. I think that it's important, though, that when you add comedy, that you don't lose track of your argument because it can be at times distracting. So although the entertainment value goes to Dr. Bilal, I think that that particular debate I would give to Dr. Caputo.
Awesome. The audience happened to disagree with our esteemed Dr. Su, and they went with Dr. Billa. So then we'll get Dr. Su's comments on our second case, which was between Dr. Emerua and Dr. Ng.
So again, this is a very, I think both did a very, very good job. I think they both had a great delivery and really, I think made use of great visuals. And I would say Dr. Ng, I liked the Mr. Bean reference and the video with The Shining. I think that really rings true to us surgeons and we get into some traumatic bleeding. I think that, you know, one of the things I would comment is on Dr. Emerua's presentation. When you have a forest plot, it's important to try to bring the audience perhaps through the forest plot a little bit better. I know that most in academia know how to read a forest plot, but maybe highlighting you know, your argument a little bit better with, you know, red dots or a box could even make that better. For Dr. Ng, I think my comments and sort of constructive criticism is that it's important to try to slow down a little bit. I think that I think we all get very nervous during public speaking. So in that, as you practice, you know, trying to slow down and be a little bit more patient makes us even better in terms of delivery. I think flipping between slides can be a tricky. And I think that when you make your slide sets complicated, this also can trip you up during a debate when you're nervous and so forth. So I'd be careful a little bit about that. But this was a close one. I gave that to Dr. Emerwa.
And same with our audience. This is our closest of all of the responses, but the edge did go to Dr. Meriwa. I happen to choose to do the robotic simple prostatectomy on this gentleman and spend about an hour doing lysis of adhesions, but that's okay. Better answer, I guess, was a whole lot. So for number 3, we have Dr. Sawin and Dr. Yee.
So I thought this was one of the best. They were all fantastic, but I think this is the one that really caught my eye of the lot. I think both had very, very strong arguments, and so this was an issue of a fine line behind the delivery and who had the more compelling argument. And although I give Dr. Slayman the bonus points for the Gator reference, you know, I will say that I think that I'm going to give this one to Dr. Yee.
Wonderful. Our audience took the converse, but that's okay. And then for our next one is Dr. Rosen and Dr. Gopal, our case 4.
So again, you know, great job to both of you guys. I love the Scarlett Johansson reference. I'm a big fan myself. I think that one of the issues is I would suggest, Dr. Rosen, making a little bit more. I think you had an opportunity to make a little bit more of a compelling argument about the oncologic outcomes or the literature regarding ablation in the time frame that you had. Instead of approaching this in a more you know, defensive manner, I would have been on the offensive a little bit more in your argument. I think that for Dr. Gopal, that was a great delivery. I'd be careful again stacking the slides. I think it just visually becomes very, very busy. I think both did very well, but both did go over time. So that is something that you have to be aware. It's okay probably in this forum. When you get to the AUA, it's highly frowned upon, and you know, everyone needs to stay on time. So I would keep that in mind when you get even more advanced and even more seasoned about your delivery. I would give this one to Dr. Gopal.
So this was another close one where the audience, Dr. Rosen just edged. Our next would be Dr. Smith and Dr. Sarcoma.
So very nice argument. This is something that I think is very topical. We are witnessing a frame shift in how we treat prostate cancer. So I thought it was a great choice in terms of the question that was asked. This was a tough one. I think that each had some areas that could be better. I think that there could have been a little bit more better evidence presented on Dr. Smith's point. I liked how you started with we will be winning. I like the confidence. I like the cookie reference. I thought that was very, very creative. But I think it just could have had a little bit more meat to it. Dr. Sarcona, I think that you did a nice job, but I think you witnessed the difficulties in making sure your slide set is the correct one that you wanted to present. And when you, all of this is about the preparation and the practice. And I know you put a lot of effort to it. And then unfortunately not having the exact slide set that you wanted to present, I think threw you off a little bit. And I think that it led to, maybe speaking a little too fast because of concern of running out of time. So those two things were things that I think affected the delivery. But in the end, I think that I would give this to Dr. Sarcona despite those limitations.
And our audience voted the opposite of that with Dr. Smith. Keep it up, Dr. So. Next one, Dr. Fram and Dr. Kosel.
Yeah, this is probably my other favorite debate. I just think that it was, both opponents were very, very well poised, and the delivery was outstanding on both sides. The Ted Cruz reference by Dr. Kosel was hilarious. I thought that was very poignant. I think it's important, Dr. Kozel, though, when you talk about and you speak about references, that you actually cite them. For those in the audience that are interested in that argument, they may want to pull up that reference. So I think it would be nice to have that citation on the slide. Dr. Fram, I think you did a great job. Saw the delivery. The stack slide issue again is a thing that I'm not a big fan of. I would give this to Dr. Kozel.
And you did it. The audience agreed with you on that. All right, for our next, Dr. Craig and Dr. Sterling.
Great job, Dr. Craig, Dr. Sterling, both. I think this was a tough one. I think we've seen this all probably from time to time, and it's kind of an ethical dilemma or philosophical dilemma. I think that both had very, very clear deliveries of their argument. I thought that the philosophical delivery, the philosophical argument that Dr. Sterling presented was great. I think the NISQIP data, I think, was very helpful. It was nice that both of you guys picked up on that. Although, again, I think that if you're going to present a table that is like that, that's fairly busy, is to, again, trying to find creative ways, either with your cursor or a way of highlighting, what you're trying to say a little bit better, I think would have been even better. In the end, I think that I was taken by the philosophical argument and the compelling evidence provided by Dr. Sterling, so I gave it to him.
And the audience agreed with you. You're on a roll now. Our last one, Dr. Shaw and Dr. Forsythe.
All right, last but not least, again, great job, guys. I thought, Anthony Fauci certainly, I think, deserves a lot of respect and a lot of our sympathy for what he's gone through. So kudos to mentioning him. I think that in the end, the evidence was perhaps a little bit better delivered by Dr. Forsythe, so I gave it to him. I think that he dovetailed very well with the opponent's arguments and almost anticipated its, lockstep. So, but both had very, very strong arguments, but I think Dr. Forsythe edged him out just by a little bit.
You finished strong. The audience agreed with you on the last one also. Again, Dr. Kavousi will speak with us, but I just also wanted to thank Dr. Su and Dr. Kavousi. And thank you so much to all of the residents. These were excellent presentations. I know we all very, very much miss being in person. This is, again, my personal favorite event that we do. And so hoping that we can do it all again in the future.
Yeah, for the residents and their faculty members, again, wonderful job. And I know for the residents, I've been there. I know these things are tough to prepare. Build on these experiences. These are really things that will make you even better at the long haul. So congratulations to all of you.
So I'm going to conclude the evening and once again thank Dr. Su. And I think by his comments, you see what kind of a thoughtful individual he is. I don't know if he's hiring, but I know that if I were looking for a job and I wanted to get out of this New York weather, I would call Dr. Su and say, Dr. Su, do you have any jobs available?
And the answer would be yes, Lou. We are hiring, and it is sunny in the mid-70s right now, and in a gentle breeze. So it's a wonderful life down here.
So any residents, I could give you a firsthand knowledge that Dr. Su is a great boss and it's a great place to live. With that, again, thank you, Dr. Su, so much for taking the time out and doing this. Really appreciate it. Excellent job. Residents, so proud of you. As president of your section, you guys are wonderful. What you've done during COVID in terms of helping take care of patients all over the city, suffering silently, what you've done with the Empire series, terrific. And I'm really proud that each and every one of you are part of our family in the New York section, really. Thank you. And finally, put up the slide again. I want to thank our industrial sponsors for this. Again, if it wasn't for industry, this would not be possible. Really appreciate your participation. Everyone have a wonderful, wonderful, safe evening and look forward to seeing you in person at a meeting in the near future. Take care, guys.
Good night, everyone.